but I also think we need to keep each other accountable. I think that's the hardest part. I think we fall into almost that peer pressure aspect where we're like, okay, well, I don't want to say anything because everyone else is doing it. No, say something. Keep them accountable, because that accountability is going to be key. It's just like how I keep my kids accountable for washing their hands. I definitely think that as healthcare workers to healthcare worker, we just be like, hey, I appreciate all the hard work you're doing, but we got to wash our hands the correct amount of time or the correct way in order to do our job effectively.
Clock in, scrub up, and join us behind the red line. You're listening to First Case, a perioperative podcast bringing you exciting interviews, engaging discussions, and innovative solutions that are changing the way patients receive surgical care. Each episode, we talk to frontline staff, perioperative leadership, and nursing entrepreneurs from across the country as they share their stories, experience, and expertise on the industry we love. From the back table to the boardroom, from wheels in to wheels out, we tackle the real-life issues affecting the OR. Whether you're tuning in for surgical service education or inspiration, we're glad you're here. And now, it's time to roll back and start the first case.
On this episode of First Case, we are continuing our discussion on infection prevention, highlighting 4 common missteps that continue to happen in our industry. And highlighting that conversation will be Erica Smith, Surgical Solutions Manager at Henry Schein Medical.
I'm really excited to get to talk to Erica today. We originally met at the AORN Expo this year, and Erica was actually in the ASC track providing education, and we got to sit down and talk, and I knew that we were going to be doing a podcast season about infection prevention, and I just really had to have her come be a guest, and she was generous enough to say yes. And we're going to really look at just these things that are so common that we overlook them, and there are ways that we can improve, and she's really going to give us a lot of good insight today.
She has great energy, and I think everybody is going to enjoy this discussion. And I don't think any of these missteps are going to surprise you, but hopefully it calls it out to your attention to just remind you to refocus your attention. So stay with us. We'll be right back with Erica.
I'm Melanie Perry.
And I'm Justin Poulin.
From the studios of Healthcare HQ, you're listening to First Case.
Today we are speaking with Erica Smith, Surgical Solutions Manager at Henry Schein Medical, and we're going to be focusing on 4 areas that are common missteps in infection prevention. So Erica, welcome to the First Case podcast.
Thank you. I am very excited to be here. So, and joining you guys today. It's great.
Well, why don't you tell us a little bit of your background and your current area of study as well?
Yeah. So I have a background in infection prevention or infection prevention and control, however you want to say it. I came from a dental manufacturer side is where I kind of got my start in this career. I went to this one, I guess, show kind of like AORN called OSAP. And that's where I learned a lot about germs and bugs and, however, it kind of just sparked this fire in me to be like, okay, we need to make sure that healthcare facilities are doing what they need to do in order to keep their patients safe. So I went from there over to Henry Schein. And I just finished up my MBA and I was like, you know what? I need to get my MPH. I started the process of applying to schools. And when I talked to the school I'm currently going to, they're like, well, you already have a master's. You've been working in infection prevention for all these years. Why don't you just go ahead and go for your doctorate? And they said, say less. Here we go. Let's do it. So skip the MPH,
That's
go
exciting.
right to the PhD. Yeah. So it's pretty cool. So almost done. We are almost done. Probably about a quarter and a half to go, but we are very close. I see the finish line.
It's always nice to be able to see the light at the end of the tunnel, isn't it?
It really is, because it was faint for a while. I think it felt like it just kept going further and further out. So it's great to see that it's right there.
Awesome.
Right
That's
there.
so exciting. I'm very, very excited for you.
Thank
so
you.
You and I connected at the 2023 AORN Expo, and you were actually speaking in the ASC track, talking about infection prevention in the ASC. And that kind of got my gears turning on how we're talking about infection prevention for this season and how could we work your expertise into this show. And I really think the missteps that we're going to talk about today are ones that maybe people just don't think about, and it really is what it is. It's a misstep. So going more broad than that first, before we dive into the details, what are just some common things that you see that are infection prevention issues when you are in facilities? What do you see a lot of?
I see a lot of hand washing missteps. We go into PPE sometimes. Maybe they're not wearing the correct thing, especially like in the sterile processing department. Surface disinfectant, believe it or not, is one of the main ones. In fact, at ARN, I mentioned that and we were talking for instructions for use. And that was the common question afterwards. I even had people calling Henry Schein to connect with me to discuss even further about the missteps when it comes to infection prevention and surface disinfectant. So that was really interesting to me to see, I guess, how common surface disinfectant was. I thought it was maybe I'm just going into a few facilities where I see it, but it's everywhere. And, just between that and maybe rushing certain steps when it comes to sterile processing or OR turnover, those are the things that I see a lot, especially because of the burnouts and, short staffing. That's where those corners get cut typically.
Yeah. Burnout and being short staffed and all of the reasons that we sometimes just let things fall because we feel like we don't have time or we're being rushed. Because I remember I had this one director who one day in our morning meeting passed out these little wall clocks that you could stick on the door of your OR. And then when you rolled out of your OR, you were supposed to push the button and you needed to be back in your OR in 15 minutes for every single case, no matter what we were doing. It's like, hold up. When we put so many constraints, of course, you can see reasons why corners get cut, why things get dropped, because people are in a hurry. And I think that leads really into us really talking about the things that you see, the problems that we have in our infection prevention. Let's talk about hand washing. What's the problem with hand washing? What goes on? What goes wrong?
Right. Well, different guidelines state, and they're all pretty much the same across the board, is you need to wash your hands for at least 15 to 20 seconds. I'm a fan of at least 20 seconds, if not more, just because as we are seeing these pathogens mutate and develop and so on and so forth, I'd rather be on the safe side. So I would prefer 20 seconds or more. And because of that, because like we said, of the burnout or short staff or maybe even the misplacement of sinks, they're like, oh, I got to get all the way over here and go from pre-op to OR to, post-op, PACU, central sterile, wherever. They're like, okay, let me just wash my hands for 10 seconds and I should be okay. When in fact, that's not the case. Some of these, pathogens, we need that 20-second hand hygiene in order to make sure that there's nothing left on our hands so we don't pass it to the next person.
So break that down a little bit further. What are we doing when we're washing our hands that's actually doing any good? I mean, is it soap? What's going on?
I wouldn't say the soap. I really think it's the time. It's the time, and do we have enough resources, sinks and so on and so forth, or alcohol, hand sanitizer dispensers in the right places? Because if we are making it further for them to go to, or let's say we're putting these 15-minute clocks on, this time now is ticking where like, okay, how can I make sure I accomplish all these things? Okay, I washed my hand for 10 seconds, the quick scrub, rinse. And then it's definitely that time constraint. It's that whether they think, okay, I don't have enough time to do 20 seconds and sing my ABCs to get there, or maybe it's they truly think that, okay, I feel like I got the surface of my hands pretty good. I think we're okay. Let's keep it moving. But it's, like I said, that 20 seconds, as well as getting all those surfaces and crevices and making sure we get like our thumbs, which are the common places missed, fingernails type of thing. That's going to ensure that we have proper hand hygiene.
It's so ironic because we get so much reinforcement during nursing school, those of us who are nurses. It's just beaten into us. I can't tell you how many classes that there is literally an hour-long lab and everybody lines up and washes their hands. But I think there is that element of the real world and the pressures of the real world, and something that seems so basic is so easily taken for granted. There are so many more complex tasks and things that require critical thinking that demand our attention that we sort of let that one go. But ultimately, you know, hand washing is the absolute key to infection prevention above all else.
Yeah, the CDC says it's the number one thing that we can do to prevent the spread of infection. And I think it was the CDC, no, it might have been World Health Organization. They did a study where they were asking, healthcare professionals, why are we not washing our hands correctly? What's wrong? And again, it's the burnout. Oh, I didn't know. Or it's, well, the sink's way over there and I got to get way over there and still come back this way. And it's just kind of crazy to think like the number one thing that we can do to prevent the spread is the number one thing we're probably not doing correctly. I think it was World Health that said that 50% of healthcare workers in the United States are not doing proper hand hygiene. That's
huge. Given how many times we put our hands on patients and how many times we are touching their stuff and we're touching them, touching others, spreading disease. And the same then would probably hold true for alcohol-based hand sanitizers. What is the appropriate technique? If you say you're not going to wash your hands with soap and water, you're going to use hand sanitizer, how should you be using that to be doing it properly?
I saw this one tip, which is make sure you have the size of at least like a Hershey Kiss of alcohol in your hand, alcohol hand sanitizer, because alcohol does dry out very quickly. And it also has to stay wet for at least 15 to 20 seconds in order to do its job correctly. So I think we just do like the one pump or the one squirt and we think, okay, that's fine. And then once it dries, it dries. If it dries before that 15 to 20 second mark, we need to make sure we get some more to continue going to that 20 second mark. So always have enough. I'd rather have too much than, too little. And I know, those that are money conscious in the facilities are like, why are we wasting so much hand sanitizer? Well, I'd rather pay the price of excessive ordering on hand sanitizer than pay the price because of spread of infection and the violations that could occur from that. It's a lot cheaper to pay for excessive.
Oh, yeah, absolutely.
stuff.
So then looking at this as this issue, this misstep, in infection prevention, how do we fix it? What's the solution?
I really think it's retraining. Just take a moment to retrain everyone. And I know it seems, elementary for it, but I just think we just need to take a step, retrain everyone. But I also think we need to keep each other accountable. I think that's the hardest part. I think we fall into almost that peer pressure aspect where we're like, okay, well, I don't want to say anything because everyone else is doing it. No, say something. Keep them accountable because that accountability is going to be key. I definitely think that as healthcare workers to healthcare worker, we just be like, hey, I appreciate all the hard work you're doing, but we got to wash our hands the correct amount of time or the correct way in order to do our job effectively.
That's very true. Very true. And sometimes that's hard because then that gets challenging and it's awkward or difficult. But at the end of the day, I like to remind myself that I'm not really doing this because I want to get on to a friend or a coworker or whatever. Ultimately, it's what's been the best interest for the patient. And we are collectively working for the common good of our patients. And so whatever we can do to make it safer for them is what we should all be willing to do. But I know that can be a difficult thing in the moment.
It's very difficult. And I know there's solutions, I think, being created in order to track that hand hygiene when they go from room to room or whatever. And I saw one that's kind of in the works where they have something on their shirt and they get close to a sink and it starts that clock, sort of thing, which is pretty cool. But I know those are probably more expensive. But as, we get newer generations will probably get better cost-effective savings if they want to. But in the meantime, if you don't have those systems to automatically monitor the free system is us keeping everyone accountable.
The truth is, there is money in it. It's just very hard to track it because at the end of the day, these infections cost healthcare organizations millions of dollars every year.
Yeah, absolutely. So let's move on to our second one when we're talking about missteps in infection prevention. And you talked about it already in the introduction, but surface disinfectants. There's a lot of confusion about those. So let's just have at it and talk about these things.
Yeah. Yeah. I think people think when they see surface disinfectant, they do, the spray, wipe, whatever. But there's more to it than that. It's the instructions for use that we have to really read and make sure we're doing correctly. And by that, I mean specifically that contact time. So, for those who don't realize what contact time is, it's how long the surface has to remain wet in order to kill that pathogen. If it says 2 minutes, it's not, okay, I wiped it, it's been 2 minutes, okay, it's going. It's, I wiped it, did it stay wet for 2 minutes? And then we can move forward with that. And sometimes that's...
I'm sorry to interrupt, but then what happens if it dries before the 2 minutes is up? We have to get it all wet again and then keep it wet?
We have to do it again and make sure it stays wet for 2 minutes. And sometimes that's hard. Yeah, exactly. With alcohol-based products, because alcohol does dry quicker. Now, that's not to say alcohol is a worse product than peroxide or any other type of active ingredients. It's just making sure that we follow that step. And when people realize that, they're like, well, that's 2 or 3 minutes and we don't have that time. Okay, if that's the case, find a disinfectant that has a shorter time that you can follow. Some hydrogen peroxides are 1 minute. There are some alcohol-based or quaternary ammonia-based that are 1 minute. Use those if we know we don't have the time to make sure it's wet for 2 to 3 minutes. And I think that's what people are like, oh, wow, okay. And then when they go on, let's say the EPA to look at that gold standard to see how long it takes to kill some of these pathogens, TB can be anywhere from 1 to 5 minutes, depending on the active ingredient. Do we have 5 minutes, to do that? A lot of times, no. So I would rather have a faster surface disinfectant contact time. It may be more expensive, yes, but again, we are killing it.
Right. And I think too, what comes to mind is a picture. I mean, I've seen this time and time again. We clean the OR, we've got our tables and our beds wiped down, and then we want to go ahead and start making the bed. And so we're standing there fanning the bed, trying to get that stuff to dry so that we can make our bed faster. But what are we doing? We're just defeating the purpose.
We're leaving the germs. That's exactly what we're doing. We are leaving the germs. I would much rather, as a patient, sit on a wet surface disinfectant bed knowing that they're killed than seeing someone, essentially fan it down. Like, all right, come on.
Yeah.
Let's go.
Yeah,
Like,
yeah.
Maybe not.
Yeah. The same holds true with that dry time on ChloraPrep as a side note completely. But when I've seen people scrubbed in and try to fan the ChloraPrep with their hand to try to get it to dry so they can finish draping. I'm like, hold up, let it dry. It kills by drying. Leave it be. And, I think we're all just naturally impatient and we don't want to wait these times. And when you think about it, 2 minutes, 3 minutes, whatever, it's really not that long. It's really not.
Right. What's 2 minutes or 3 minutes compared to, okay, you have an outbreak from Candida auris, or you have, let's say, C. diff somewhere, that's a lot.
Yeah.
And think about the combination of these first two topics and how they work together to really cause a lot of problems. Because if we don't allow for the dwell time and that bacteria is living, it's more likely to get transferred onto our hands. And then, especially when we think it's now clean, right? So that's more likely to get transferred onto our hands. And then if we're not hand washing, it's that much more likely to get to a patient. So it can be compounding, correct?
Yeah, absolutely. It's a snowball effect. And we just have to make sure we are, as healthcare workers, we are breaking that chain of infection somewhere or another. And hand hygiene and surface disinfectant are the easiest ways to break that chain.
So you touched on a solution talking about finding products that might have a shorter dwell time, but is there any other way that we can really improve so that we can do better with our surface disinfectants?
Yeah, I think it goes again back to that training aspect. I think we need to have not just that annual training with OSHA and so on and so forth. I think we need to have continuous training throughout the years to make sure that we are following the instructions for use. So I think everyone should read the instructions for use on whatever chemicals they are using. Make sure they understand it. Me personally, I would almost kind of test to make sure like, hey, we're using blah, blah, blah. What's the contact time on it? Okay. How do we use it correctly? Okay. All right, good. And then it's again, that accountability piece. Are we making sure that we are doing these steps correctly? And if we're not, okay, let's go back to that training aspect. The other time I would make sure that we are making sure we're following anything is anytime we switch chemicals. So if we went from a 1 minute to 2 minute or vice versa, let's make sure everyone knows there's been a change. It's from this to this. So let's make sure we're all doing that correctly. And again, test, quiz, train continuously. Look for CEs maybe that touch on this topic as well, just to ensure that, everyone within that facility knows exactly how to use the product.
Yeah, that is really key. And I think really understanding using the product correctly. Like you said, it's not just I wiped it down, now I wait a minute, but it's if the IFU says I've got to keep it wet for this amount of time, actually doing what it says and understanding those IFUs. I know that but prior to being part of First Case and being brought into Beyond Clean and all of these brands, I don't think I really fully understood the purpose of the IFU or what you could find out about the IFU or why you needed to even pay attention. But those are a gold mine they should be, of information, and you can access so much in those IFUs.
Right. Yeah. When in doubt,
read the IFU.
Read the instructions for use. Read the IFUs.
Yes,
and I would rather someone pause to double check that than just assume. It's those assumptions that are getting to us because we're like, oh yeah, I'm sure it kills this, or oh yeah, I'm sure it did it in 30 seconds. When really it was like 8 minutes. And they had no idea.
Right.
So always refer back if there's any type of hesitation. Just stop and confirm before moving forward.
Yeah, absolutely. All right. So we have talked about hand washing and areas that we may be overlooking with our hand washing and obviously surface disinfectants. That's really a mind-blowing one to me to really think about what I've seen in practice, heck, what I've even done and what is actually correct. And there's a lot of ways to improve there. So let's talk though now about instrument transport. What are we doing wrong? What can we do better?
Whew, the things I have seen with instrument transport. It's not just the biggest thing. It's like the main thing that I see continuously is that we are not putting these instruments in a sealed, leak-proof container to transport back into sterile processing. Case in point, I was in a multi-specialty ASC. I was in an OR watching, I think it was a GI procedure at the time. And then we go to leave. They're doing their thing with cleaning up. And I go back into sterile processing. And I see those same instruments uncovered in his hand and just plops it on the table next to me. And I was like, oh my God. Oh my God. That was just in someone in a place that I don't want to be. And now it's next to me. And I was like, absolutely not. But that's common. And it's common. And that's the scary part. It's very common. Again, it's right there. I'm just going to take it right there. Or we don't have the leak-proof containers that is needed. And they just assume that it's okay. And that's the crazy part of it. Like, it's far from it. And just the nonchalant.
I'll just throw a blue towel over the basket and carry it upstairs. It'll be fine.
Right. Well, theirs was just in their hands. There was no blue towel. There was just in their hands, It's scary. There's another story of someone I used to work with. This was more in a dental setting, but still, it has effect. They were in the sterilization room, and one of the dental assistants comes walking around with 3 source patients' instruments on a open tray. She ran into the person, and 3 different instruments penetrated her foot because, again, it wasn't covered. So she had to go through that process of taking the medication to reverse potentially any bloodborne pathogens. And I heard it was miserable. But again, all of that could have been avoided if it was in the right container in the first place.
Sometimes I feel like the containers aren't marked properly either. Like, I also feel like if there isn't a single owner of what is happening during the transport, or it's not part of a one-way process, and I'm definitely thinking about different clinics and not necessarily surgical settings, or they're more like day surgery, less invasive type procedures. I feel like that can happen even more so. I realize we are focused on the operating room, but so many times the container that they're being transported in are just not even indicating that it's dirty or that it's a biohazard, that it is not clean and sterile. And I think that remains today to still be a huge visual understanding or communication that is lacking in many facilities. Or they'll have bins, but they don't say biohazard on them, and they might be red, but then people will use them for both purposes. So then again, like, it's red, but if it's used for both purposes, then how do you really know if what's inside is clean or sterile or dirty?
And as you stated, if it's not the one person who's continuously handling that aspect, let's say they go on vacation, or let's say they leave, or, they're sick, or whatever it is, whoever takes over that spot for the day should be doing the same exact steps. So we know when it comes in, it is a biohazard, it's been used, or, whatever case, whatever it is, everyone should be trained on that. So if you have to step in the role of someone else, we're not quickly spreading things.
It needs to be sustainable so that we're all being consistent with the process.
Right. The consistency is key, because again, if we don't have that, we skip those steps and we reuse instruments that were in a GI procedure to someone else. So, so that's
actually the environment I'm thinking about, because a lot of those are happening in a clinic, but they are still very much a surgical procedure, not necessarily like a day. That might be a day procedure, but absolutely, that's the setting I've seen it, especially scopes being transported in pillowcases, plastic bags. That's where I think there's a ton of opportunity potentially.
And just gross thinking about it. Like I said, I had the heebie-jeebies when I just watched them just place it down, and I was like, you know what? I'm gonna go out there. Y'all keep doing what you're doing.
Well,
I'm going to go shower.
Well, because things, you plop that down next to me, who knows what could have bounced off or spread. I mean, things move. And then tangentially too, something that is very prevalent in the OR, and I think it has to do with awareness, and it has to do with time as well, and being pushed for turnovers, is the amount of times that equipment. So we're not talking about instruments. We are talking about equipment that is in the room, but equipment that is in one room, that has been in the room while a patient was in there, whether it was used or not, but it was in the room. It's needed in another room. It gets grabbed and it gets rolled right into another room to be used without being cleaned in between. Yes, it's equipment. It might not be directly touching the patient, but if it's been in a room when a patient has been in there having surgery, then it has been exposed to the elements of surgery. And who knows, once again, what could have dropped on it, been splattered on it, gotten on it. And then we just roll it right into another room and have it in there with another patient. You're like, we could be doing better. And we need to make sure these are clean every time they roll into another room.
Yeah, there's so many things that are ambient in the air. And it's even like, with the first procedure of the day, it's good to kind of wipe things down again, because anything that was in the air has settled down on the equipment or anything around there. So it's best practices again to make sure we're doing that quick, but we're cleaning them up. Yeah. Before we start the first procedure of the day. And again, people
don't think about it,
realize that, but you would think that COVID exposed that, because before we weren't thinking air as much. We weren't thinking air as much. But then COVID showed us air is just as effective in spreading things as it is with physical contact and blood-borne pathogens. And you would think that even after that, we would be more cognizant of what's going on in the air. But I think we got past the scare. And now we're back to what we were before COVID. Like, okay, that's done. Let's get back to
comfortable.
Moving us.
We get comfortable.
Yeah, very comfortable.
Yeah. And that's where we make mistakes and where we slack off, and things can possibly cause a problem.
Yeah, we slack off and things slide in.
Exactly.
And that's the issue.
Exactly. Well, that actually leads very well into this fourth misstep, talking about PPE. And there are so many different types of PPE and so many different things that we wear in the operating room. But that can be a big factor in infection prevention. What have you got for us? What are we doing wrong, or what have you seen?
I think the one big one I see is in the transport and cleaning up, but then also in sterile processing. There's certain gloves and attire and aprons that should be worn while we handle these instruments to prevent any type of percutaneous injury. And a lot of times I don't see the aprons or the special gowns as going to prevent any type of fluid coming onto them. And they're just using the regular thin gloves when we're dealing with sharp instruments that have not been sterilized, that are still contaminated with whatever it is that's coming from the OR. And they're just handling it as if they won't get stuck. And maybe they haven't, but there's going to be that day where something drops on them or something splashes on them and they're not wearing the right attire in order to protect those orifices or mucous membranes or, with the skin or whatever it is. And that just opens the door for the staff themselves to get something. And I've seen areas where they are head to toe in the right PPE. They got the hair covers, bouffants or skull caps. They got the goggles. They got the utility gloves, the shoe covers. And I'm like, I know I could probably lick the floor of this facility and it's probably
please don't.
You still want to do
No.
it.
But seeing that makes me,
confident.
Be like, okay, you're doing the right things. But then we go back to that one area where he just brought back the instruments and just dropped them down. Were any of them wearing what they should have been wearing? No. They just had scrubs on and regular gloves and nothing else to protect them from those elements. And I know, like in the OR, sometimes I see things, maybe they're not donning and doffing the PPE correctly. However, because there are, certain methods and guidelines that must be followed in the OR, I don't see it as much. Whereas sterile processing, they're like, well, there's no patients back here. There's no one, we don't have to be as careful because there's no one open on a table right now, so that's where I start to see that slack or lax in PPE. And it's just, to me, I would rather be full hazmat, to make sure I don't take anything home to my kids and to my family. I'd rather be wearing everything and knowing I'm not spreading anything versus maybe today's the day. I catch Candida auris.
Yeah, let's not catch
infection prevention roulette. Yeah, right. Whatever it is. So
one of the things that I have actually recently encountered. I mean, you bring up the point that there are so many strict guidelines in the operating room for what we have to wear to scrub in, and yet I'm recently encountering this idea that, well, look at our infection rates. Our infection rates are so low. We don't actually have nobody's ever coming back. So it doesn't really matter. And I legitimately had this conversation with somebody the other day because I was talking about the fact that I saw someone scrubbing in who consistently scrubbed in with silicone bracelets still on their wrists, and they weren't taking them off when they scrubbed in. And I'm like, you can't wear those underneath your gown and gloves. That increases the bacterial count. It's not allowed. They need to come off. And the response is, but we don't really have very high infection rates. So why do we need to be doing all of this stuff if we're not actually seeing any patients come back with infections? And so this idea creeping in that, well, maybe it is okay. Maybe I don't have to follow all the rules because I don't ever see these patients coming back. And that is very scary in the thought of how we are actually working to protect our patients.
Yeah, I almost feel like it's like, imagine, would you want to get a surgery in your own facility with that same thought process? That's what you have to ask yourself. If you're going to say, no, I'd rather have everyone in this, or I don't care if the silicone bracelet's on, which I highly doubt you would say, then you need to reevaluate, just reevaluate. I'm, like I said, a stickler for it. Anytime I find doctor's offices or if we have to have surgery and something, I ask those questions. And sometimes they get annoyed, but it's like, these are my babies.
Exactly.
This is my body. I want to make sure that I know that you guys are caring for me across the board. And that includes instruments and, the transport and PPE and hand washing, that includes all of it. That does affect the patient.
Exactly.
Hands down.
Exactly. And it protects us as well. You know, it's affecting our patient, and then it's also affecting us and what we take home to our families, what we expose our children to, our spouses, our parents, anybody. So there's a big domino effect of exposure when we aren't doing what we're supposed to be doing to protect ourselves or to protect our patients.
Erica, I totally agree with what Melanie is saying there and what you're saying about not bringing things home to our families. And I also want to kind of put this out there to the vendors who are out there. Like, many people at the hospital have dedicated shoes that they leave in their locker, but vendors are going from one place to another place. And I'm just a firm believer of wearing shoe covers, especially because you do wind up wearing those shoes at home, and you could be not even in just one environment throughout the day. You could be in multiple hospital environments. And a lot of times I'll see people not wearing shoe covers, you know, when they go down to decon to drop off their set of trays. And they might even just be at the door of decon, or they might be assisting on the clean side and getting the tray ready before it goes up to the OR. I just want shoe covers on all the time. And, you know, I remember when I first got out of my nursing scrubs and into my vendor rep suit, you know, I had a mentor who said, listen, your kids are playing on the floor at home. If you're wearing these shoes all over the facility and then you're coming home and wearing the same shoes around your house and you're not taking them off at the door, you're potentially exposing, you know, your own family. And kids pick stuff up off the floor and put it in their mouths all the time. So he really implored us to think about that. And ever since then, I just constantly beating that drum. So there's the vendor side of that too, you know, just increased exposure from being in so many different places. Erica, really great job on this interview. Is there any final thoughts or anything you'd like to add before we wrap up?
Yeah, so safety shouldn't be something taken for granted. We can't assume we're doing everything correctly. We can't assume, like you said, we're not bringing something home to the family. And to me, it's just imperative to consistently train, keep everyone accountable, and just make sure that we are doing everything from top to bottom how we should be, and not skipping those steps or cutting corners. Because the second we do that, the second we get slack, the second we get complacent or assume, hey, like you said, Melanie, our infection rates aren't there, we can cut back on this. That is the second something comes in and an outbreak occurs, or someone gets sick, or one of our staff gets affected by this. And it's just, to me, very, very important that we always, from the time we clock in to the time we leave, we are doing everything by the book to make sure that everyone has that safe aspect within their facility.
You know, it was a very exaggerated example of what you're describing, but how many people lived in their camper during the pandemic when they were going to work in a hospital, or got a hotel room, or found a way to quarantine themselves? So while it may be a less deadly conversation, you know, statistically speaking, it is still, I think that highlights there was a reason people did that. And I think it emphasizes the use of PPE. So Erica, great job. Thanks for coming on.
Thanks for having me. This was great. I absolutely enjoyed it. Let me know if I need to come back and talk more horror stories.
Everybody loves a good horror story.
Yeah, that's right.
I'm just saying, I'm sure I'll encounter some here, you know, in the near future. But thank you so much for having me. I appreciate it.
That was Erica Smith, Surgical Solutions Manager at Henry Schein Medical, talking about 4 areas that we all can just really be paying close attention to with some common missteps in infection prevention, starting with hand washing, moving to surface disinfectants, then instrument transport, and that one's a favorite of mine, as you noted, Melanie, and PPE. And all of these seem on some level to be very foundational in terms of skill set, and yet they continue to be glaring opportunities for improvement, Melanie.
Yeah, absolutely. I think that's why, because they're just foundational things. We're so used to them. We do them every single day. And then we just don't think about it. And Erica had a really good point when she just said that consistency is key. It's just so important that we are consistent in our hand washing, in using our disinfectants correctly, in transporting our instruments, and in wearing the appropriate PPE. We're consistent in doing them correctly. And then on the flip side, we're also consistent in auditing and making sure it's being done correctly. So just lots of good reminders and key takeaways from this interview today. And definitely, I'm headed to the OR tomorrow, so it will definitely be on my mind to make sure that I'm doing all of these correctly as well while I'm in the OR.
Well, I would love to just make a call out to the listening audience as you see the post announcing this episode on LinkedIn or Facebook. Maybe there's something else that you see on your daily routines that just make it obvious. Oh, this is why this keeps happening. Would love to hear that discussion, because I think sometimes, to your point, Melanie, not only do we sort of take it for granted, but we take our eyes off of it, and we might even notice certain things, and it just becomes not a priority in our minds, and really it needs to maintain one. So I'd love to hear other people's feedback. Also, while we would love for you to comment on our post, we'd also like for you to share it out. And if you're not so public and you have some comments for us as we continue to bring episodes and content and topics to the forefront, we'd love to hear from you by email. That'd be a more private communication. info@firstcasemedia.com. You can connect with Melanie and myself. Make sure you're following the First Case brand on social media. On behalf of Melanie and myself, thank you for listening to this week's episode of First Case.
Thank you for listening to this week's episode of First Case. As a reminder, you can help support us by subscribing to First Case on your favorite podcast app or by downloading the smartphone app on iPhone or Android. Simply search for First Case in the App Store or Google Play. The best thing about downloading the smartphone app is that you can access bonus content for certain episodes and view episodes in certain categories, like articles on the go and vendor spotlights. Are you following us on LinkedIn or Facebook yet? If you are and you love an episode or post, then let your social network know about it. Like, comment, or share our posts along with your thoughts and keep the conversation going. If you have any topics or guests that you would like to recommend for a future episode, just send us an email to info@firstcasemedia.com. We look forward to hearing from you.